Well, good evening, ladies and gentlemen, and welcome to you all to this Research Tuesdays, Beating Childhood Diabetes. I'd like to start by acknowledging the Ghana people, the original custodians of the Adelaide Plains, and the land on which the university's campuses here at North Terrace, Waite, Theberton and Roseworthy are built. I'm Alistair Burt. I'm the Executive Dean of the Faculty of Health and Medical Sciences at the University of Adelaide, and I'm delighted to welcome you this evening. Thank you for coming along to the final Research Tuesdays for 2016. This year we've showcased many areas of research that the university is involved in, from gravitational waves to forensic science, through to heart health, vaccinations and computer science. It's been an enlightening year, and we thank you very much for your interest and attendance. But tonight we turn our attention to an important disease, type 1 diabetes. Over the past 20 years, the rate of childhood onset type 1 diabetes in Australia and around the world has doubled. And tonight's research that you hear about looks at how our modern environment and the exposures that a child has in early life might hold the key to understanding this increase in the disease. Our speaker this evening, Professor Jenny Cooper, is Head of Paediatrics at the university here. She is an accomplished paediatric endocrinologist who leads the Women's and Children's Hospital Endocrine and Diabetes Unit. She also leads the National ENDIA, that's Environmental Determinants of Type 1 Diabetes study, and the cardiovascular investigation in Australia for the International Adolescent Diabetes Intervention Trial. So tremendous accolades internationally and nationally, and it's a delight for me to introduce her this evening. Following our presentation, we will invite questions from around the floor, so I do encourage you to get involved at that stage. But first, let's welcome Professor Jenny Cooper. Jenny.
Thank you very much, Alistair, and thanks everybody for coming. It's a very busy time of the year for you all. The little girl on the left was the first child in Australia to receive insulin, which was shipped out from Toronto. Her father was a merchant banker, could afford to ship it out to Sydney, and in 1922. And it was a miracle at that time, and discovered by Banting and Best in Toronto, here with their Marjorie the dog. The first insulin in Australia was actually made by the Professor of Physiology at University of Adelaide, Professor Robertson, and given at the Children's Hospital down the road to a little 6-year-old boy. So quite a bit of history involved at Adelaide. This is a little person who I look after, and we give the insulin as a very similar looking insulin that we give to the one that was given to the dog in those first trials, but children with type 1 diabetes enjoy much better diabetes control over the last 20 years. However, as I'll explain, it's still an enormous burden to the child and to the families. It's continuous and daily, and even with new technology, still a very hard disease to cope with. We can give insulin by pumps and also measure glucose continuously by these little monitors, and they can speak to the pump so that now when the glucose starts to fall, which may be dangerous if it fell too low, the insulin can stop the infusion and then turn back on again as the glucose starts to rise. And about 50% of our children at the Children's Hospital, or the clinic of about 700, actually wear these insulin pumps, but they're not yet fully federally funded. So we've come a long way. Children have to do a lot more every day, but it does make them a lot more healthy. They have much better monitoring of their diabetes, their overall control is much better, and consequently the risk of long-term complications, which we are so concerned about, is much lower than it was back before the 1990s. We have a large network around the country that we've just set up over the last couple of years around the different children's hospitals of about 7,000 children at present with type 1 diabetes, which is growing. And it really allows us to make sure we're up to our game and how we compare with other centres and look at different ways of doing things around the country. Despite all these efforts, type 1 diabetes is one of the things that's really been on the rise in children in the last 30 years. So in the last 30 years, we've seen the overweight epidemic, which we're all very conscious of, both in children and in adults. Type 1 diabetes has increased, as Alice has mentioned, type 2 diabetes to a lesser extent, and some other disorders, inflammatory bowel disease, celiac disease, allergies, autism spectrum disorder, and attention deficit hyperactivity disorder. So these rises have been quite substantial, and really you have to look at the environment to explain them, and particularly something that's modifiable in the environment so that we can try and curb these increases. So the evidence for the role of environment really lies in this increase in incidence, and we haven't had as many data points in Australia, but if you look at the blue line here, the incidence has doubled from the 1980s. And it's about the same as US, but you see this very striking increase in Finland, which has the highest incidence in the world. These are in children under 15, and it's six-fold what it was when they first had very good registers just after World War II. And some interesting geography and in relation to the incidence of type 1 diabetes. So Finland, which has the highest incidence in children in the world, is next door to Russian Karelia with very similar genes in their population and has one of the lowest instances in the world of type 1 diabetes. And the emerging economy, Estonia, is somewhere in between. So very interesting geography and differences. Obviously our environments have changed, and we're all very aware what we eat's changed, we're more hygienic. We're older when we have our babies, we're heavier when we have our babies, most of us are heavier than our grandparents, unfortunately, and we have more antibiotics and we have less sleep. So the modern environment is obviously very different than if we go back to the 1950s, 1960s even. What happens in type 1 diabetes pathologically is the immune cells invade the clusters of cells where the insulin-producing cells are. So scattered around the pancreas, which just sits behind our stomach, are little clusters of cells, a bit like currants in a bun, and the immune cells invade these areas and destroy the insulin-producing cells. This is quite a patchy destruction. We used to think it was complete and all the cells were destroyed, but we now realise it's quite patchy, which is very important for people with type 1 diabetes, as I'll come to later. Once this is occurring, the person starts to develop antibodies to these cells, and we call that islet autoimmunity. And it's a technical term, but an important term to use because it's our first real evidence that this child is on their way to type 1 diabetes. If they have 2 or more of these islet antibodies, they've virtually got a 100% risk of developing type 1 diabetes during their life. So we see these different stages of type 1 diabetes. The first stage, you just have the islet autoimmunity, and you've got a normal blood glucose, and this is the stage when some trials are occurring to try and curb it. Then you have a stage when your blood glucose is starting to rise, and then eventually we have the more clinical stage where the child starts to get the classical symptoms of type 1 diabetes and will often present to the general practitioner at this stage. But we do know that this change in the pancreas can occur very early, long before the child presents to the GP with diabetes, and in some children as early as the first year of life. And in fact, in large studies looking at children, this is actually some US work, but it's not dissimilar in Australia, the first appearance of this occurs between the first year of life and through to the 3rd year of life. So really very early in the life, which begs the question, what's the pregnancy in relation to this we could possibly modify to help? There are many genes in type 1 diabetes. This just shows the yellow code as the ones that have been most recently discovered. The blue code are the big ones and the ones we still concentrate on. And it's not that everybody has the same genes, but there are many risk genes in type 1 diabetes. And to look at this whole question of what's going on very early in life, back since the 1990s, birth cohorts, as we call them, following children from birth at risk of type 1 diabetes was set up. And we had our own Australian one between South Australia and Victoria. But more recently, the contemporary cohorts are the TEDdy study, which stands for the Environmental Determinants of Diabetes in the Young. I think they probably got the best acronym there between USA and Europe, which is a very large study, and sort of our competition in a way, and India in Australia. And there are the folk in India. We had one of our face-to-face meetings at the Adelaide Oval on a lovely night. We got them all together, which is hard to get everyone together for a photo. And what we're doing is we're following children from the pregnancy who have a mother or a father or a brother or sister with type 1 diabetes, putting them at increased risk, and looking at lots of different things in the environment that may impact their risk of type 1 diabetes to see what we could modify. We're the only study in the world following babies from the pregnancy, which was in part inspired by the Robinson Research Institute's very big interest in the pregnancy to early life, because, and as such, that's why we've really been able to go ahead and do this study with funding, because it is unique in the world. And with lots of old friends and new friends from around Australia. These days, these big efforts really do need a lot of collaborators, and you do spend quite a lot of time on teleconferences and bring everybody together. So the families in this India study from pregnancy, where the little babies got a first-degree relative with type 1 diabetes, are followed from birth to 3 years very intensively, and then less intensively afterwards as they go through childhood. And we have questionnaires, we have assessments of the baby and the mother, we have biosamples, and it's a very detailed study, and vast numbers of biospecimens per participant are being generated. We differ from TEDdy. You've got to differ from TEDdy, not be a Me Too study in order to keep going and produce the literature, because our babies have first-degree relatives with type 1 diabetes. The babies in the TEDdy study in US and Europe have genes at risk of type 1 diabetes, which is a slightly different group of children. We follow them up from early pregnancy. It's a very, very detailed study. And we're an Australian population, which is likely to have different things that are modifiable in the environment probably than other parts of the world. So we recognise that the things in the environment that could be implicated can either trigger the islet autoimmunity, and we think this is probably happening from very early life. And then once you've actually got that islet autoimmunity in the pancreas, something makes it progress to type 1 diabetes, and there are also going to be protection factors, which are obviously also very important. And there's no shortage of factors that have been studied or hypothesised to be important. And I won't go through all of these, and I apologise for all the writing, but just to show the wealth of studies that have already been done, but none particularly conclusive on what could be driving all of this. I'll just mention two of the Australian discoveries that we've been involved in. First, we showed in our first study that babies' weight gain in the first 2 years of life increased their risk of getting the islet autoimmunity if their weight gain was rapid. And we also showed that once they've actually got the islet antibodies, they'll progress to type 1 diabetes more quickly if they are less sensitive to insulin. So weight gain, we think, is very important, where after all, the incidence of type 1 diabetes in children, the rise of it has really paralleled the overweight epidemic. And our Australian data has shown this rapid weight gain in early childhood to increase the risk. And we think that mothers' weight before pregnancy, about almost 50% of mothers when they begin their pregnancies are overweight. And the weight gain during the pregnancy may also be very important to drive all this process. In Finland, they had been interested in the protection of breast milk and the harmful potential effect of cow's milk protein, which gets introduced in cow's milk or in babies' formulae when they're weaned. So they did an enormous study looking at whether removing that cow's milk protein from the infant formulae could protect the children. Cost $132 million, just to give you some idea of how much these studies cost, and was the first big primary prevention trial in the world, and unfortunately showed no benefit. So very disappointing, because they had some preliminary data suggesting it might show some benefit. Other culprits in early life nutrition have been gluten, so the wheat, vitamin D, which has been topical in many areas over the last 5 to 10 years, and omega-3 fatty acids that are also talked about a lot. But despite some evidence, particularly epidemiologically, there's really been no definite conclusions about any of the early life nutrition factors yet. It does seem that for babies, the best time to introduce gluten and other solids is around the 4 to 5 months of age, which is recommended, and if you're breastfeeding at the time you do that, that may be protective in some studies. Vitamin D has been a bit inconclusive, and now there are very large gene studies being looked at with various modelling methods that are very clever to look at all the vitamin D genes and all the type 1 diabetes risk genes. And likewise, omega-3 fatty acids have been looked at in much more detail, because we're realising now that simple studies just aren't going to give us the answer. We have to really get into a lot of depth to tease out what matters and what doesn't matter. Gut viruses as a possible trigger for type 1 diabetes have been around for some time. We all get enteroviruses or gut viruses, particularly in early life, and they have been shown to be more increased at the time of a child getting these changes of viral autoimmunity, which is interesting. In the very, very few children who die at the diagnosis of type 1 diabetes, which is exceedingly rare in the world now, they have shown the proteins of the virus in the pancreas, and enterovirus infection or gut infection during pregnancy and early childhood may also be important as a trigger, and we're looking at this very intensively in the India study. So why are there so many different findings and different studies over the last 20 years, which is slightly frustrating? Well, we know there are interactions between the genes and the environment, and there are also interactions between environment and environment. And we think our studies up until now have not been detailed enough and not looked into things complexly enough to really get down to what's going on. We're also starting to realise that type 1 diabetes is heterogeneous, and by that I mean there are different types probably of type 1 diabetes, different genes, different rates of onset, presents at different stages of life. There's early childhood and adolescent, and then some adults like Theresa May, the Prime Minister of UK, got type 1 diabetes in her 50s, so people can even get it in their 80s. So we think these different types of type 1 diabetes aren't being driven by exactly the same thing in the environment. And there are also different patterns in the pancreas of the inflammation. So I think we've been making it too simple, is what we feel. And meanwhile, while we've been doing the studies, there's been this explosion of what we call the OMIT technology, which are these technologies which are aimed at looking at all the genes in a biological sample, all the proteins, or all the metabolites, or all the microbes, and it gives you an enormous amount of information which can then be generated and is a very powerful tool for looking at things in great depth. So we've been able to design India with this in mind and bring in a lot of these new sciences and experts to give it a lot more depth. We've been particularly interested in the human microbiome, the microbes that I talked about, which you probably know are all the bacteria that are currently all over us, and particularly in our guts, trillions of them, that co-inhabit our bodies quite happily. And this is very interesting to paediatricians because the human microbiome changes very rapidly in early childhood. It's very interesting in type 1 diabetes because its importance is in the development of the early infant's immune system, which is what goes wrong in type 1 diabetes. And it's also altered by the mode of birth delivery, whether it's caesarean or vaginal, early nutrition and antibiotics in early life. And of course it can be manipulated. by probiotics and prebiotics and antibiotics. And so it may be the common route through which environmental triggers act to push on type 1 diabetes in a child. So we're very interested in that area, and as are many people in the world. We've got a bit of a battle going on in our society at the moment. We're very hygienic. We're cleaning the toilet with Clean or the floor or whatever, and we're also taking probiotics at the same time. So we're on one side killing germs, on the other side we're sort of giving ourselves germs, which is an interesting dichotomy at the moment. And in the first 2 years of life, as I said, the microbiome in the gut of the baby is changing quite rapidly. These colours are just the different types of bacteria. It doesn't change as rapidly as this again in life, so it's very interesting that time of life to look at it. In the placenta, in the pregnancy, we know less about the microbiome. There have been 2 conflicting studies. We don't really even know whether it changes much during the pregnancy, and we know that the microbiome exists throughout the mother and indeed in the fetus and in the placenta around the baby, and we're looking at this in depth in India right at the moment. The first studies of the gut microbiome in children who have already developed autoimmunity do show some differences, and the most interesting results have come from Finland, where they've shown a specific species of bacteria. Sorry, I'll just go back to that. The Bacteroides dorii actually spikes around the time solid foods introduced in these Finnish children, who then go on to get autoimmunity. So very interesting, and I'll come back to that. We don't have any such species yet in Australia, but it would be lovely if we could find one, because this is potentially treatable. But when you're doing all these exciting new things, you have to keep calm and make sure you haven't got too excited by it all, because we do now have an ability to make a lot of mistakes very fast. Just going back to that map I showed before with the different instances between the different countries, someone I worked with in Toronto a long time, Michael Nipp, has just completed a study where they looked at the microbiome in the babies, just the normal population, not babies who have got type 1 diabetes in these countries, and interestingly show that the gut microbiome in Finland and Estonia was different than that of the Karelian babies, and in these babies, they showed that a proliferation of that type of species that they'd shown up in the children who went on to get autoimmunity. So very early, but very, very interesting results. The dad doesn't get off scot-free here. We tend to think of dads providing the sperm and that's it, but we now realise that the life of the dad around 3 months up until the baby is conceived is important for the child's health. And nutrition, the weight of the dad, the fitness of the dad, smoking and his age are all important, and in many cases just as important as that of the mother. And this is because we realise that sperm have chemical switches that are attached to the DNA in the sperm, and they're induced by dad's diet, his lifestyle, etc. And these switches, called epigenetics in the sperm, can affect the baby. So in India, we're looking at the father, and that would be the first time anybody's looked at the father as well as the mother. We think that's very important. When you're going to do intervention trials in people at risk of type 1 diabetes, you really have to have a global approach. You can't really set off, certainly in South Australia, even in Australia is really too small to do intervention trials properly with adequate numbers to really get a result. So we have a big network of centres around the world looking at trials and doing them together. This is John Wentworth, who's in part of our India study, and he's also leading the Southeast Asian part of the diabetes trial net around the world. And some of the prevention studies we've done in relatives with autoimmunity in Australia have been the intranasal insulin trial, which came from Melbourne, and was the first trials were done in Melbourne and in Adelaide, and then around the country. And then we've got children also in the oral insulin trial, and some other what we call monoclonal antibody trials. And these are all trials trying to modify the immune system, so they're not altering the environment in any way, they're modifying the immune system to see if you can slow it down to preserve the insulin-producing cells and slow down that attack. In newly diagnosed children. We haven't got any studies going in Australia yet. There are some in the US, and there's been one agent which has seemed to have slowed down the attack, because even after you've got type 1 diabetes, you still have quite a lot of insulin-producing cells, and we still have an attack going on, at least for a few years, and so it's an opportunity to try and get in there. Because anybody with type 1 diabetes knows if you can preserve at least some of the insulin-producing cells, it just makes life a whole lot easier. If you've already got diabetes for some time, you can well think, well, this is not much help. But what we do realise now, that even people who've had type 1 diabetes for a long time, many, in fact, perhaps almost most, have still some insulin-producing cells. They're just simply not enough to make any benefit on lowering the glucose in the blood. So if we can understand what preserves the function of the insulin-producing cells before diabetes develops, we think that will be very useful information to know how to help people with long-standing type 1 diabetes regenerate some of the insulin-producing cells. So we feel that both the prevention and the cure, if you like, are connected, and that's what a lot of the work all around the world is being aimed at. We're also likely to need different agents and different combinations for different people. And this is very much the personalised medicine, which we're seeing for a lot of diseases now, is very evident in type 1 diabetes as well. Just a little pause with some lovely root burn track scenery from New Zealand and my homeland. Just to, as a physician, it's always nice to be able to do some research and investigation with the patients you're actually looking after, try and solve some of the problems they have as well. And in addition to the interest in the prevention of type 1 diabetes, we've also been very interested particularly in blood vessel disease complications and how we can prevent them in children with type 1 diabetes. Because the modern environment, when you think about it, has affected children with type 1 diabetes in several ways. It's doubled the incidence, and we don't know exactly what is the main culprit over the last 3 decades. We know a third of children who present with type 1 diabetes are overweight, very different picture than 50 years ago. And that overweight epidemic that we all are part of also has an effect on blood vessel disease in addition to the diabetes. So back in 1922 to 1960, we had pictures of really quite emaciated children before they got insulin and then putting on weight then. Now in 2016, a third of the children will present actually overweight. And it's only by looking at some of their other features we're really sure this is actually type 1 diabetes. The other reality is that heart disease begins in all of us in childhood, very, very early on. So from childhood, we have the very first changes in our blood vessels that eventually, in some of us, will cause heart disease much, much, much later in life. So if you're going to get in early, there's an opportunity to do an awful lot of good with relatively straightforward interventions. We're interested in heart disease and diabetes because the benefits of good diabetes control, which has really improved substantially over the last 25 years in children with diabetes, have had a big impact as they grow up on their kidney health and their eye health, but not so much impact on their heart health. And women are protected from this in the same way they are in the non-diabetes population. And we also know that risk factors for heart health in childhood track into adulthood. We can't, fortunately, look at children developing heart disease problems and diabetes because they just simply don't get them, thank goodness. But we can measure their blood vessel health with ultrasound techniques, and just a little plug for the Women and Children's Hospital and its amazing ultrasound department, and Roger Gent, who's a bit of a legend in Australia and internationally in his ability with ultrasound work, who led the ultrasound side of this research with us and has worked with us for the last 15 years. So you can look at the structure of the vessels by ultrasound, and you can actually measure the thickness in these little white boxes here. It's coming up there for you, and here on a child, absolutely painlessly, of course. And we can also measure the function of a blood vessel by looking to see how well it dilates when you blow up a blood pressure cuff and then let it go. So I'll just show this video. So this is just you can see the blood vessel making the little beaty movements there. and then we blow up the cuff and it gets a little bit restricted, just like you take a blood pressure. And then when we let it go, you can hear the blood coming through faster and it's dilating. We can measure how much that dilates as a marker of health in children, and quite accurately look at their blood vessel function that way, and again painlessly. And with using those types of techniques, we've been able to show that children who are overweight without type 1 diabetes have comparable changes to children with type 1 diabetes, which was interesting. We've shown that even children who are a little bit above average weight, it can affect their blood vessel health. We also showed that giving extra folate can improve their blood vessel health, but not after mandatory folate fortification of wheat, which began in Australia in 2009, which is interesting. So it's no longer of benefit giving extra folate to children. And we've also showed that the blood vessels which are first to thicken in diabetes are the ones in the abdomen, the large vessels there, which was very important because when we do intervention trials, we've got to have some way of telling whether we're doing any good or not, because children, as I mentioned, do not get heart disease in relation to their diabetes, fortunately. So in this big study between UK, Canada and Australia, we did a trial to look at protecting the heart and the kidneys in teenagers. Many people said we were crazy to try and join together as 3 countries and study teenagers with their sort of lifestyles in this way, but we did it. And it was a lot of fun, and these are the Australian sites involved around the country, the children's hospitals again, mainly in the adult study. And what we were doing was, we know the star shows where we would normally be intervening once people are really into their adult life to protect against progressing to kidney and heart disease and diabetes with the first sort of very early signs of problems. But we were trying to intervene earlier with the same type of medications, but intervene earlier just as they're starting to tip towards this stage. So very early. These are children from about 10 to 16, so much earlier, to see if that helped. And lots had to be screened for the study, and to get the right group, and Australia, as usual, pulled its weight. And we went, and we were very pleased to find that we could slow down any progression onto this stage for kidney disease by starting much earlier. So this will change our clinical practice. We'll be starting these sort of very low doses of blood pressure tablets much earlier now in the clinic in children, before they've actually got any signs of any issues at the beginning, because we can slow this process down, which is great. But we didn't really detect any help by giving early statins, which are the lipid-lowering agents that some of you may be on as adults. And this is probably not because we didn't do any good, but probably because our ultrasound measures, unfortunately, as we were the site for Australia doing this, weren't quite sensitive enough to pick up changes. And this is the big problem in children. It's quite hard to see changes. So we're following these children on for a bit longer to see if we have helped as we look over as they enter into young adulthood. So we think that might show some important changes, and again change our practice, how we manage these children in the clinic. We've also done a study of metformin, and some people possibly may be on metformin in the room, because it's a very, very common medication, a very good old-fashioned medication that's got very few side effects and is used commonly in type 2 diabetes. But because a lot of children with type 1 diabetes are overweight, we were wanting to see whether this metformin could help in addition to their insulin, and particularly whether it could improve their blood vessel function. And we showed, like another study in the US, which started at the same time, that we could improve their control of their diabetes, we could reduce their insulin dose, which is good, and we could also improve their blood vessel function a little bit, but not hugely, but a little bit. And we also showed that, in addition to some of the common things known about blood vessel health, that to our surprise slightly, that the salt intake of these children, which was very high, like most adolescents, did seem to matter for their blood vessel function, and we realised we hadn't really been concentrating on that dietary advice very much to keep their salt at a reasonable intake in these children. And on a positive note, we also showed that for every extra 1,000 steps a day that these children took, that actually improved the look of their blood vessels, they weren't as thick, and also improved detectably their cholesterol and their blood pressure. So even just an extra 1,000 steps a day, which is not very much really, made a difference. So that was very good news. And just some more good news is a fascinating study in Boston in US, my final a couple of slides called the Jocelyn Medalist study, which follows patients who are happy to be followed, who've had type 1 diabetes for over 50 years. In some cases, they've had type 1 diabetes for about 70 years and are completely free of any complications or any signs of complications. And 2/3 still make a tiny amount of insulin, looking at very, very sensitive measures. They're all on insulin, but they make a tiny amount of insulin in their bodies. And they're being looked at to look at their genes and look at their lifestyle and what protective factors might be out there, because we tend to concentrate a lot on the bad factors, but not so much on the protective factors, and they're just as important, of course. And just going back to my very first slide, the little girl who got the first insulin in Australia from Sydney on the left, she died at the ripe old age of 82 in 1998, and we know her diabetes control would have been very high and just couldn't get good control with the old schedules. So there are certainly some people out there who have the right something to protect them even without our help. So I just want to thank the Vascular Study Group, which works at the Women and Children's Hospital with me, but includes a number of people from the University of Adelaide, and including our biostatistician and some of our PhD students and the sonographers and some of the people that have worked with me for some time now, and particularly Dr. Alexia Pina, who has been a colleague now for almost 20 years, just here. And also the India group, who are the hard workers in South Australia, many of whom are funded by the University of Adelaide, who are a wonderful team of people and other funders for that study. And I'm a member of the Robinson Research Institute, which really in many ways gave me some of the ideas for the India study, and I thank the Women and Children's Hospital. So thank you.